This is an item to receive an update on Monterey County's Esperanza Care Pilot Project for the remaining uninsured in our county and provide direction to staff concerning their enrollment cap. And we have our health department director, Elsa Jimenez, and Dr. Gary Gray from Inpatient. Oh, or substitute.
My name is Dr. Lawrence Cabell, and I'm the CEO of Debrief.
And Bob Mackler, who's the VP for Civic Health License.
Okay. Oh, now it's on. So good afternoon. Unfortunately, Dr. Gray could not be here to provide this presentation. So I am here along with our partners at Pacific Health Alliance to provide an update on your expansion of our pilot project for Remaining Uninsured called Esperanza Care. Just to kind of refresh where we've come from, in August of 2015, your board approved approximately $500,000 of general fund to provide necessary primary care, limited pharmaceuticals, laboratory, and radiology services for the remaining uninsured. I will remind you that there's anywhere between up to 60,000 individuals in Monterey County that unfortunately, because of their documentation status, remain ineligible for health care services. Our pilot project ran from November of 2015 to approximately September of 2017, and we served about 2,000 individuals. In May of 2017, staff returned to your board for direction going forward, and your board at that time, as part of the fiscal year 17-18 budget, approved an allocation of $2 million from the Natividad Medical Center's Enterprise Fund to enroll up to 2,500 individuals and expand services. Part of that direction was to contract with the third-party administrator, Pacific Health Alliance, and that was executed in August of 2017, and then we implemented Esperanza Care starting October 1st of 2017. Esperanza Care brings over what we were doing with our pilot project, but really added additional services, specifically in the area of specialty services. So $1.8 million of the $2 million is allocated for actual direct care, $200,000 for the administration of it. Who is eligible for Esperanza Care? We have it bulleted there. Low-income individuals up to 138% of the federal poverty level, individuals 19 years and above, those that are currently uninsured and are not eligible for other comprehensive medical coverage. And as I mentioned previously, this is a closed network where we provide full-scope primary care offered through the health department's outpatient primary care clinics, and then Natividad-based specialty care services, including lab, diagnostic imaging, and limited generic drugs. This is just an outline of the scope of services. Because of time, I won't go through them. But again, it added much requested and needed specialty care services. What is not included is mental health, substance use recovery, inpatient, emergency department, surgery services, as outlined here, and any out-of-system care. So as was directed, we brought on Pacific Health Alliance to serve as our third-party administrator, and they're going to provide an overview of the topics mentioned on the slide there.
Great. Well, thank you. Pacific Health Alliance was brought on in collaboration with the county, and we developed what we thought would be an appropriate administrative program. Enrollment, the issuance of membership cards, member notices, things of that sort. Keeping track of a wait list, we'll talk about in a second. But those are some of the services that Pacific Health Alliance provides. In terms of the first 5 months of actual services, we've seen some interesting demographics. There's, at the end of February, there was 498 people enrolled, 75% female, 25% male. Obviously, no one under the age of 17, and the preponderance of folks between the age of 30 and 49. So it's kind of a middle of a developed curve, if you will, population. Although there was a pretty good senior population. If you look at the numbers, there's about 7% over the age of Utilization, about 61% of the people who enrolled utilized some type of service in that time period. As we get into monthly growth, as you can see, September was the first real month where we had actual enrollment. We had about 430 people, and it quickly escalated from there. 2498 in February, and we closed enrollment, I think, about February 18th, something like that, February 15th. So enrollment growth was robust, obviously. In terms of the wait list, that particular slide has 80 on it. As of today, there's 135 on the wait list. So we're growing at about 7 to 8 people per day are being added to the wait list. So that's pretty significant growth. The next slide shows the type of diagnoses which we're seeing, and this is in a descending rank order. And it gives you findings here is that it's primarily diabetes-related, immunizations, hypertension, obesity, and of course, in the middle of a huge flu system, and so we had quite a bit of that, and also female-related type disorders, not unlike a traditional health type. Next one is what do they come in for? And again, since this is a primary centric program, most of them come in for primary care. We had 2,440 office visits through the end of February. A lot of office visits in that short period of time. So we're having almost one office visit for a person, but remember some people have more than one visit. But as you look at that list of the top 25 codes, if you will, being office visits, and a few other things. So how's the program performed through February 28th? This slide actually can give you an idea of what the true costs of the program are. At the top, the clinics, they generated for themselves about $282,000 in revenue, and that is an interesting structure. It's a capitation type structure where they're paid $28 per enrollee per month. So if you have 10,000 people enrolled, you get 10,000 times 28. And we have about 10,000 member months through the end of February. I think it's 10,100, something like that. Hospital, they're paid on the Medi-Cal value, and so a hospital bill will come in, let's say it's $1,000. It's adjudicated vis-a-vis the Medi-Cal value, which the state is familiar with, and they get paid a percentage of that bill charge. So they generate about $41,000 in revenue. As of today, it's just shy of $50,000. Pharmacy, pretty good utilization of the pharmacy program. It's already sitting at about $120,000. Administration, close to $70,000. And then IBNR, that's incurred but not reported. And so we have to take a look at how the claims come in and estimate what hasn't come in yet. That's obviously necessary to have a well-run program, and so we have to keep track of that particular number. But we are, I think, quite lucky in the sense that I think our estimates are, if anything, a little bit overestimated, and that's because the capitated program with the clinics, once we cap them at $28, doesn't matter what the claim comes in, it's part of the pay. In terms of administration, it's a set fee. Pharmacy, it's a fee-for-service type program. The hospital is somewhat of a fee-for-service program. The hospital tends to submit claims very quickly, and so they're turned around very quickly. All of that relates to a relatively low IBNR, much lower by the way you define the plan. So from the beginning to the end of February, we're looking at just shy of $53 per member per month in terms of the total cost of the plan. So we tried to estimate what it would cost if we ran this out through the end of June, everything being the same, trend being the same, and we come up with a number of a little bit over $1 million. So it's a rather successful program. I think the next slide puts another little figure, and we move that number up to about 1.2 million, because again, we've calculated an IBNR in there, just in case that at the end of June, the program is terminated, we still have claims that you have to pay. So so we kind of put aside that estimation or that calculation there. Then we made some assumptions. Assumption A is what would happen if we kept this at 2,500 people. Well, it's going to run about $59, maybe $60 per member per month, and it would cost $1.2 million to do it. Well below the $2 million for the South. So if we expanded the cap and brought it up to 3,500 on April 1st, remember you don't just expand the cap and everybody just enrolls on the next day. People, it's an enrollment process, so you have a gap in enrollment. But let's assume that we went from 2,500 to 3,500 on April 1st and then carried that through into June. We'd still be looking at about $59, $59.58 on a PMP per member per month basis, and the number would rise, the total cost would rise to about just shy of 1.4 million. If we move the cap to 4,000, we increase that cost to about a little less than 1.5 million, and if we expanded it to 5,000, we would something like that. So the program seems to be operating well within the budget parameters provided. Obviously, we keep a very close eye on the eyes and arms as they plan to move forward quickly, and we'll be happy with the process.
So today we are here not only to provide an update of where we are with Esperanza Care, but really to seek your direction on moving forward through the remainder of the fiscal year. We have three options for your consideration. The first option is to maintain enrollment at 2,500 individuals and the established wait list. Option 2 would be to increase the enrollment up to 3,500 and establish a wait list. And option 3 would be to increase enrollment until funding is exhausted. Until funding is exhausted and not establish an enrollment cap. So with that, we will take any questions that you may have.
Right, we will open this up for questions, comments. So it's Supervisor Parker.
Thank you, Mr. Chair. I do have a couple of questions. Thank you very much for this presentation. I guess my first question is, Natividad was willing to step up and say we'll provide up to $2 million for this project this year. Dr. Gray's not here, so can you speak for him? As to whether Natividad is contemplating continuing this next year, the commitment of $2 million?
You know, unfortunately, I can't speak for Dr. Gray.
So we can just assume that he will, so that's good. Since we were told earlier that NMC is structurally sound, I believe were the words of Mr. Woods. Okay, well that's kind of a big question. Then I had a question, just because I didn't, under excluded services, how many of those services would folks be able to access through emergency Medi-Cal or some other coverage?
So the excluded services, if it was an ED visit or hospitalization, staff at Natividad work with the patient to see if they are eligible for other coverage, as you mentioned, emergency Medi-Cal. So, or they would go on our sliding fee scale, or they would just become part of charity care.
Okay, so the inpatient hospital services or emergency room visits are likely, could be, but not surgery, not every surgery, maybe some?
Potentially. I mean, again, they would look to see if they qualify for emergency Medi-Cal, for ProCal, for any other type of coverage that may be out there.
Okay, but in general, run-of-the-mill mental health or substance use wouldn't be covered?
So if somebody has is diagnosed with a severe mental illness, then they would enter the health department,
County
behavioral health services, and receive services through that system, whether it be that we try to get them on Medi-Cal or that they become just part of our cost of doing business to provide SMI services to everybody.
Okay, so that would be for a severe mental illness, but still not for just regular need for counseling or substance abuse treatment or anything?
So if they need for counseling, like if they have a mild to moderate diagnosis, you know, these individuals are already connected to our primary care system. And to some extent, we do provide behavioral health services, counseling of that nature within our primary care setting for those that are diagnosed with a mild to moderate. Now, in terms of substance use, I can't speak to that, but I can get a definitive answer for you. But if somebody were to be hospitalized in the inpatient mental health unit, then the county, through its health department, would pay for that care.
Right, thank you. So part of what you were saying was that some mental health services are provided through the primary care, the fact that it's a full primary care.
Correct.
Okay, thank you. And then just something I didn't understand on these charts with the different codes that are being utilized. I could understand the under bill charges versus the allowed columns. I could understand that bill charges might be a bigger number than what was allowed, but for instance, on slide 14, the second from the top, hepatitis B vaccine, bill charges were almost $4,000 and allowed charges were $10,000. So I guess I'm just trying to understand what the numbers in these two columns mean.
One is the first column is the actual bill charge. The second column would be what would be the allowed charge if we were to price this at a Medi-Cal value. It doesn't mean we pay them at that. It simply means that that would be what that array of services will be priced at if we use the Medi-Cal value. Why did we use the Medi-Cal value? Because it's a universal metric, at least in the state of California. So we can compare a unit of service with another unit of service. Whether it's right or wrong, that's a whole other debate, but it's a method of comparison.
So then looking at the first line on that chart, where the bill charges are $230,000 and the allowed is $38,000, there's a pretty big gap there, that we have a higher utilization and cost than we would be able to bill for at Medi-Cal rates.
You have a higher bill charge, a significantly higher bill charge per unit of service. So 99213, for example, which is an office visit, this is brought here, 99213. It's fairly few. Most providers will bill at a certain level or within a certain range, and they're going to build into that building, if you will, contractual allowances that they're going to experience through the entire course of their practice, any other discounts, any bad debt, any types of things in that. Medi-Cal, on the other hand, doesn't quite care about your bad debt. They're going to come up with a value that they feel is appropriate for that particular service. And interestingly, for that particular service, it's about $24 the Medi-Cal value, as opposed to Medicare, which is about $75, $80 for that same service. So there's a difference in how that's calculated. But in terms of figuring out if the program can be compared, when we were putting the program together, I think everybody was in agreement that this is a pretty good way to compare things. Don't think it's not perfect, but it's not a bad way to compare the apples and the semi-apples, if you will.
And so then when you're talking about the costs of providing services, about which I also have a question, are you using the bill charges?
No. Yeah, we're using what we would have paid under Medi-Cal, with a major exception. Since the county clinics are capitated, if you will, they receive $28 per member per month. So if there's 1,000 members, they get $28. We're still going to value the services, the claims that come in. And so the county submits a claim. We still value that claim based on the Medi-Cal value. But the actual cost was the $28 per member per month. So in an aggregate, kind of take a look at that aggregation of costs over time.
Thank you. And so then looking at the chart with, let's just say, the assumptions on it, A, B, C, and D, can you tell me what the annualized total would be? So these are numbers that start on August 1st of 2017 and they end June 30th, if you were to add 2 more months into there, I'm trying to get an idea of what direction I might be comfortable giving in terms of the number of people that we should try to build into this to stay within our budget, more or less.
And that chart was hopefully that chart addresses your question. So what I did was I took a look at the numbers and said, okay, let's make a few assumptions. The first, we'll just look at assumption A, for example. What if we didn't gain any more members through the end of June? And we're going to run at 2,500, everything's going to be level at that point. What would be the total cost, including the IBNR? And so that comes out to about $1.2 million. Maybe we could get the possibility of doing that, but up on the screen. So that would come to about $1.2 million annualized. And annualized, by the way, I want to put an asterisk by that because it started really October. So it's not really a 12-month amortization. Assumption B was made with the assumption that we were going to increase this to 3,500 people, and that the ramp up to 3,500 would occur all on April 1st.
Can you move your mic closer, please, because you're having a hard time.
Okay, would occur all on April 1st. We'd ramp it to 3,500, so you'd have 3 months of 3,500, and then whatever we had built up to that point. And so you can see what the total cost would be, roughly $1.376 million. Assumption C, move that to 4,000, and assumption D, move that to 5,000. And so you can see corresponding increases. Interestingly, the PMPM drops a little bit. That's probably because you're getting some scale, if you will. Not much, but some scale in that particular program. So, if you wanted to run that out for a true 12-month period, I'll just do a quick calculation. I'll just do 3,500. You're probably looking at about $2.4 million at the highest.
Good, your math matches mine. Good, I never trust mine, so I appreciate that. Okay, great. And then I just have some other questions that, like, are we getting any feedback about whether what we're offering in this program is working for the members? Are they asking for things that we don't provide? How are we doing? Do we need to go back and look at adding or subtracting, adding things to the benefit package to meet the needs of the community?
Supervisor Parker and Bob Mackler. Our staff does get calls every day on, that's our role is to service the community as well. And certainly there are items that are not covered under the way that the system is structured. It might be a certain type of test that's not performed, or it's sent out from Natividad to an outside laboratory. And I know we've recently received some question on cardiology testing, some non-invasive testing. But I have to be honest, we have not gotten a ton of, gee, we're not getting anything that we want. It's very positive.
Thank you. And then I know when we started this, we were saying that this has the potential to not only provide hopefully some better health outcomes, but save the system money. And I know Dr. Gray was very cautious about making any of those promises. But are we in any position yet to say anything about where some savings might be happening in terms of some of the, keeping people out of the emergency room is kind of the obvious one. Is there any way to measure, more days at work or anything like that that we can build into what we're tracking and measuring?
we need to have a few more months of experience to be able to make those kinds of leaps in terms of, presumptions that if you provide preventative care, you might reduce ED visits. We've only implemented since October, so I would say probably after the end of June, we might be able to do some analytics to see if we did perhaps avoid an ED based on prior history of a certain patient, for example. So I would say that we could have a report July or August that could help respond to some of those questions.
Yeah, I know it's early, but it does seem as though it'd be interesting to take a look. And then also the fact that there are a couple of other hospital clinic systems in our county who are probably benefiting from this or stand to definitely over time, as well as employers. So anyway, I think that's probably enough questions for me for now. Thank you.
Excuse me.
Other supervisor matters?
Yes, thank you very much. Mine is a sort of a follow-up to a question that Supervisor Parker had, because I too was under the impression that there are some specialty diagnostic tests that can't be offered because they're not essentially in the program formulary. And I'm wondering, I know, Elsa, that we've talked to you about this a little bit, and I'm wondering if it's true, number one, and number two, if it is, have we done any kind of an analysis to see how much it would cost to add those kinds of tests in?
So what I understand, and Bob can chime in, is more recently there's been requests regarding the services provided at our new cardiology clinic in Natividad. So these would be non-invasive tests such as EKGs, echoes, stress tests, etc. And as you know, those are currently not included in the program. What we are telling patients in the interim is that they can sign up for Natividad's self-pay discount program. And a quick comparison of what the charges are and what that discount is, it's about 10% of what the costs are. I know that administration is going to go back and revisit with their medical staff in terms of, the formulary, the test, to see if there is an opportunity to expand that would still meet the objective of trying to serve, the largest number of people possible with preventative care, balancing that with some of the needs that we're seeing more recently with the new individuals enrolled in Esperanza.
Okay, thank you so much, because I'm interested in expanding this. It's just wonderful, and I thank all of you for the work that's being done, but I do want to make sure that people get what it is that they need, and this would be clearly one of the, I don't think it's just because it's the newest opportunity. I think it's because there's a real prevalence of heart disease in our community. Good, thanks.
Other supervisors?
Just briefly, thank you. I understand things are working well with the third-party administrators do that. We were hoping that this is kind of like a satellite project that it might get picked up with some state money here. We haven't seen any of that, so we're back to Dr. Gray. And at what point in time, I think we're looking, and if we haven't used all our money and we have a waiting list and we're at 2,500, at least expanding to 3,500, but is there a concern if we expanded that one that we might run out of money where the original 2,500 couldn't keep getting?
So if you look at the table that's shown on the screen, it's a matter of, do you want to spend the full $2 million now before June 30th? Before July 1st. We could expand, but then the question becomes, what's going to happen come July 1st into the coming fiscal year?
Okay, I just want to add, could you go to the chart 4 slides back? Why do you just have to this one?
I'm sorry, I'm going the wrong way.
Down.
Oh, what? That one?
So 4 to the last slide.
Can't.
See, estimated program cost, right?
That.
Yeah, so
Okay,
as we're
sorry.
looking at, I met with our community stakeholders, and we did make a commitment to fund the 1.8 million for Esperanza Care with the 200,000 needed to administer it. That kind of lets you know where we're at right now. In terms of looking at predictability to stay within budget, but meet the goals that we committed to the community, is it better to have a fixed number and add a certain number of more? I know there's currently 80 people on the wait list, or is it better, like on that option C that you pointed out, which is just to keep the program going until you reach the $2 million approved amount, to stay within budget? I don't know what's more predictable, to just increase the cap, or have direction that says we're going to continue to provide funding to additional people up until we run out of the money.
I think it would be good to increase the cap up to a certain amount, because then you have an opportunity to hopefully meet the full needs of that individual that's been enrolled, especially if we're going to be revisiting and adding some of the other services that currently aren't covered in the pilot program. I think an increase would be good, and not leaving the enrollment cap, open-ended.
Right, because I can see where, because I don't know how much we'll expend from, almost at the end of March, April, May, June, 3 additional months. And if somebody enrolls and money runs out, do we cut them off mid-June? I'm not sure if that's even possible, but I can see in theory, you always plan for any type of scenario. So I'm just trying to meet the goals I'm hearing from the community, but also making sure that it's practical, and that when somebody enrolled would somehow then, at the end of June, perhaps get services cut off because we reached the cap of the money approved for this particular program.
That's why I took a look at doing a little protection of this. It'd be great to expand it to whatever, but I don't think that's the safe and prudent thing to do. I think the safe and prudent thing would be to move the cap up a reasonable amount, let's say 3,500, because we still have 4 months of data to add into this, and 4 months on top of 5 months is nearly 50% of that, and so it can change literally on a dime. So I think being much more prudent is better. At that point, when we receive the full year's data in, or close to the full year's data in, then we can take a look at some other possibilities. Do we want to add a couple of things in terms of service rate? Do we want to move the numbers of people for the following year up or down on that? I'm comfortable with the data as of today. In fact, before we left today, we ran some numbers through the end of the day yesterday, and everything seemed, the first 3 months of March seemed to be working like we had hoped. It hadn't moved much in terms of the actual PMPM. We don't have the pharmacy data, so we couldn't comment on that, but it looks like the trend is starting to establish itself. And if that's the case, then when we get into the end of May or the first part of June, I think we can start to address with a little more confidence some of the questions that I'm sure people are asking. Do we want to expand? Do we want to decrease?
And we expect that when we approve this program, and this is now year 2 of this program, we knew that we were going to learn from it as we went along doing this. What was learned were areas that we could perhaps expand a little bit. We're always kind of cautious because in local governments, this is all coming from our local funding without the state support. But nonetheless, it's an effort that we've committed to the community, trying to expand healthcare as much as possible. And I do hope the state legislature could continue to expand. We undershould expand healthcare to children regardless of their immigration status under Med-Cal, but now we have a lot of adults that are in the same need of healthcare. And I always like that quote by Dr. King, who said that out of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. And so for this new pilot program to see that we are utilizing it, that it quickly reached the cap that we thought was going to take us a full year to implement, shows that the need is out there, but that these services are really going a long way to help with the most critical needs of a lot of our local residents. And it's worthy of continued support. But I think at the end of this your program, we'll get the full data. Not too far down the road, we could have a better analysis of how we could refine this program in the next fiscal year. But at least till the end of this year, I'm good with trying to look at now that number, that the 3,500 that we might be able to include and fully serve to the end of this current fiscal year with the money that we committed to. Thank you. We'll now open this up for public comments. I got 4 speaker cards. Is there anyone else? We're trying to get another big issue after this item. I have 4 speakers. Is there any other speakers beyond these 4? Okay, so we give the 4 3 minutes. We'll start with Alfonso Ramirez, then Monica Palomo, Maria Rendon, and then Maria Elena Manso. We'll start with Alfonso. Unless you want to take them in a different order. Yes, sir.
Hola, ¿qué tal? Muy buenas tardes.
Deja que aprendan el micrófono.
Good afternoon.
Hola, ¿qué tal? Muy buenas tardes. Mi nombre es Alfonso Ramírez
My name is Alfonso Ramírez.
y soy miembro del programa y me estoy beneficiando de él.
I'm a member of the program and I am benefiting from it.
Quisiera ustedes apoyaran este programa porque en mi caso yo tengo más de 8 años en este país.
I'd like you to fully support this program because in my case, I've been in this country for more than 8 years.
Y nunca he tenido atención médica. Creo que es necesario.
I have never received medical attention. I believe it's necessary.
Creo que es muy necesaria, en especial la preventiva, porque somos nosotros las personas que tenemos que ayudar y trabajar para los que están atrás de nosotros.
I believe that preventive medicine is the key because we have to work for those behind us.
En mi caso, les digo, yo he tenido directamente hasta ahorita la ayuda porque tengo una cita fechada apenas para el 1 de mayo.
I have benefited from this program because I have a date for the 1st of May.
Y ese día va a ser la primera vez.
And that day is going to be my first appointment day.
Yo no estoy diagnosticado médicamente por diabetes tipo 2,
I don't have a medical diagnosis for diabetes type 2.
pero yo sé que lo tengo porque durante un año, 5 meses aproximadamente, yo me he checado el azúcar y la tengo alta.
But I believe that I have it because in 12 months I've been regularly checking my blood sugar and I know that it is high.
Entonces, yo tengo entendido que la diabetes pues no te mata luego,
So I'm under the understanding that diabetes doesn't kill you right away.
pero sí es una enfermedad degenerativa que me va a ocasionar daño en los riñones, en el hígado, en el corazón.
But it is a degenerative disease that will weaken my liver, my kidneys, and my heart.
Entonces creo que hubiera sido bueno si yo lo hubiera prevenido, posiblemente no la tuviera, y ahorita en este momento que la tengo, pues quisiera tratarla.
So I believe that it would be a good thing to have done preventive care for it in order to avoid treatment for it now.
Y gracias a este programa, a este apoyo que tienen ustedes, voy a poder acceder a él para tener el beneficio.
And thanks to this program, I would have access to it to get the benefits of it.
Entonces espero le den más expansión y que no quede nomás en esto, en un programa que sucedió y de repente se espumó.
So I hope that it is expanded and that it doesn't end up in a program that was created and it just smoked away.
Y no nomás estoy pensando en mí porque ahorita yo tengo ese problema, sino pienso que sea más a futuro para los que vienen. Creo que somos una comunidad trabajadora.
I'm not just thinking about myself, I'm thinking to those that are coming behind me because we are a working community.
Venimos a trabajar a esta comunidad y uno de los beneficios humanos debería ser la salud.
And because we're a working community, one of the human rights would be health.
Entonces me gustaría, la gente allá afuera los apoye ustedes y creo que en este momento ocupan su apoyo.
People on the outside are supporting you on this and
Su apoyo.
they are waiting on your support.
Yeah. Entonces, pues no sé, la decisión está en ustedes, pero creo que sí sería bueno tomar en eso porque no nomás somos 2.500 los que pertenecemos a este programa ahorita. Hay muchísimo más gente atrás de nosotros.
So I'll leave you with that. It's just not 2,500 people in the program. There's many, many more that are waiting up for that.
Entonces, la prevención es lo mejor y en su defecto la ayuda y pues espero que sean muchísimo más que esos.
So prevention is the key, effect is the answer, and I'm looking forward to more to it.
Les agradezco por su atención. Muchas
I
gracias.
thank you for your attention. Thank you.
Gracias, señor Ramírez. Gracias, señor Ramírez. Mónica Párez, perdón.
Buenas tardes. Me llamo Mónica Palomo, soy del Comité de Salud para Todos. Hoy estaré leyendo la historia de Amelia Chico y su familia, ya que Amelia no pudo faltar en su trabajo.
Good afternoon. My name is Monica Palomo. I'm from the Health Committee for everybody. Today, I'm going to be reading the history of Amalia Chico and her family, since Amalia could not be here in this work.
Soy Amalia Chico, residente de Greenfield desde 1998. Recientemente me enteré del programa Esperanza Care en una junta comunitaria en Soledad. Me interesó mucho aprender sobre el programa, ya que recientemente me enteré que tengo colesterol y prediabetes. Por mi trabajo en el Debrief y el costo de la vida tan alto hay aquí, no me alcanza el dinero para mantener a mis dos hijos y seguir con mi tratamiento médico.
I am Amalia Chico, Greenfield resident since 1998. Recently, I became aware of the Esperanza Care Project at a community meeting in Soledad. I was very interested to learn about the program since I was recently diagnosed with a high cholesterol and pre-diabetes. With my job on the field cutting broccoli and the high cost of living here, I don't have enough money to maintain my 2 children and follow up with my medical treatment.
En mi familia, yo no soy la única que se beneficiará de Esperanza Care. Mi mamá, Gloria Tamayo, de 60 años, sufre de diabetes, alta presión, tiroides y depresión. Este mes tuvimos que juntar $700 para sus medicinas. Aunque familiares y amigos nos prestaron dinero, este mes no podemos seguir endeudándonos por todo el interés y el no saber que el siguiente mes tendremos las medicinas. Mi mamá ha tenido que ir a la sala de emergencias por su depresión.
In my family, I'm not just the only one that would benefit from the Esperanza Care. My mother, Gloria Tamayo, 60 years old, suffers from diabetes, high pressure, thyroid, and depression. This month, we have to get together $700 for prescription medicine. Even though relatives and friends lend us money, we cannot keep on falling in debt. With all the stress and not knowing what the next month is going to bring us as far as prescription medicine for my mother, we have attended the emergency room in the past for her depression.
Mi papá, Román Chico, de 73 años, tampoco califica para un seguro médico. Mi papá también tiene diabetes y ya no puede caminar de tan hinchados que tiene sus pies.
My father, Roman Chico, 73 years old, does not also qualify for medical insurance. My father suffers from diabetes and he can no longer walk due to the swelling in his feet.
Me duele mucho ver a mis padres sufrir con sus enfermedades y la falta de seguros. Aunque logramos juntar el dinero para los medicamentos de mi mano, este mes no sabemos cómo va a ir al siguiente.
It pains me greatly to see my parents suffering with diseases due to a lack of health insurance. Even though we can get together the money for the prescription medicines for my mother, this month we're not sure how we're going to do for the following month.
Les pido de favor que expandan el programa de Esperanza Care. Contar con la cobertura de este programa es una gran ayuda para mi familia y la familia. Gracias.
I ask you a favor to please expand the Esperanza Care program to rely on the coverage that this program will provide. It will be great help to my complete family and the community. Thank you.
Thank you, Ms. Palomo, and also for helping our interpreter with your copy of your notes.
Oh, it wasn't Spanish. Not in English.
Yeah, but it makes it easy when you have all the words written out. Okay, next we have Maria Rendon.
Good afternoon, Board of Supervisors. My name is Maria Rendon. I'm a COPA leader at San Pablo Episcopal Church in Kingston. I was at the launching of the Esperanza Care back in October 2017. I quickly decided to organize an information session at my small church, and over 30 people enrolled that night. One of my close friends shared his story to me. He was getting very sick around that time, but did not seek medical care because it was completely out of his big family budget. He enrolled to Esperanza Care and immediately booked an appointment. He was diagnosed with diabetes and high cholesterol. Doctor ordered blood work, prescriptions, and follow-up appointments. And told him that because it was detected early, it was reversible with the recommended lifestyle changes, diet, and exercise. And this is what he said to me. I feel like I came back to life and my family is now healthy and happy. Thanks to Esperanza Care for the treatment and preventive care. Thank you.
Thank you very much, Mr. Rendon. Next, we have Maria Elena Manso.
Good afternoon, Board of Supervisors. My name is Marilena Manso. I'm a COPA leader from Sacred Heart Church here in Salinas. Since 2015, COPA has organized to make sure that first the pilot project and now Esperanza Care are successful projects. Despite the weather, we have people here from COPA. If you can please stand up to be here in support of Esperanza Care. There were some startup problems identified at the beginning of Esperanza Care that we brought up to the health department, and the issues were successfully resolved. We meet regularly with Dr. Gray and Director Jimenez to make sure that this program is improving and effectively serving residents in Monterey County. One of the differences between the pilot project and Esperanza Care is the access to specialty care. We have learned that some of the tests and specialists that specialists need to effectively serve their patients and the prescriptions that they write are not covered by Esperanza Care. So we spoke with Dr. Gray about this issue, and he agreed to review the current coverage, and I know that they will have heard words in that regard. All this information is leading us, COPA, to support option 2, to increase the enrollment on Esperanza Care to 3,500 members, because we do want to make sure that there are funds available to pay for the diagnosis test that the specialists require in order to address the needs of their patients. So that's our recommendation. Thank you very much.
Thank you very much, Ms. Manso. Is there anyone else who would like to speak? That's here today. Yes, please come to the mic. It was good to see everybody stand up. I thought you guys were all here for the next item on calendar.
Hola, muy buenas tardes a todos.
Hello, good afternoon to everybody.
Mi nombre es Consuelo Rosales y también pertenezco a COPA.
My name is Consuelo Rosales. I also belong to COPA.
Yo vengo nuevamente a agradecerles y a pedirles que extiendan el programa, ya que yo me he beneficiado de ese programa.
I come again to thank you and to ask you to extend the program because I have beneficiated from the program.
Hace tiempo aquí estuve parada llorando de dolor
Long time ago, I was standing here in front of you crying in pain,
y ahora me encuentro muy bien gracias al programa.
and now I find myself very well thanks to the program.
Y por lo tanto les quiero agradecer que sigan expandiendo ese programa para que igual que otras personas
Therefore, I want to thank you for expanding the program so that other persons as well
se vengan a beneficiar al igual que yo y estemos bien con nuestra familia.
will benefit as well as me and will all be well as well as our families.
De antemano, muchas gracias y que Dios los bendiga.
And beforehand, thank you very much and God bless you.
Great story. Thank you for coming today. Anyone else?
Muy buenas tardes.
Good afternoon.
Mi nombre es Ricarda Rodríguez.
My name is Ricardo
Yo
Rodriguez.
trabajo por la comunidad.
I work for the community.
Vengo a representar mi comunidad del este.
I come to represent my
Yo
community from
tengo
this.
unos, apoyando a la comunidad un poquito más de, creo que unos 30 y tantos años.
I've been supporting the community for 30 plus years.
Pero esta vez yo les quiero pedir, suplicar que apoyen el programa Esperanza.
But this time, I want to ask you and I want to beg from you to please support the Esperanza program.
Yo he tenido la oportunidad de no beneficiarme yo, pero a través del programa yo he podido darle la información a otras personas de la comunidad.
I have had the opportunity to benefit from the program, but to also give information to the members of the community about the program,
De cual ellos se han beneficiado.
from which they have benefited.
Entonces, si ellos tienen el beneficio, yo estoy bien, yo estoy contenta
So if they have the
por
benefit,
ellos.
then I'm very happy
Y
for
yo
them.
les pido pues que no nos dejen solos.
So I'm asking you to not leave us alone.
Este programa es buenísimo, nos está apoyando, no se imaginan en qué cantidad.
This is a very good program. You
Yo
have
trabajo
no
para personas
idea
que
as to
no
how
tenemos
much this
documentos.
program is supporting us. I work with people that don't have any documents,
¿Verdad? Pero sí tienen mucho corazón y tienen mucho amor por este país.
but they have a lot of heart and a lot of love for this country.
Y ellos quieren la oportunidad de tener una buena salud para mejorar dentro de sus propias familias primeramente y dentro de su propia comunidad.
And they just want to have better health so they're better within their family as well as within their community.
Muchas gracias.
Thank you very much.
Gracias a todos
Thank
ustedes,
you to all of you.
como padres de familia, como miembros de este comité, como seres de este mundo. Muchas gracias por ese corazón tan grande que tienen y yo sé que nos van a seguir apoyando.
As parents, thank you for the big heart that you have, and I know that you will keep supporting us.
Y me hacen que yo me motive para seguir adelante también.
And you make me get motivated so I can move forward too.
Muchas gracias.
Thank you.
Hi, I just want to add something. My name is Miriam Rudd. I'm a student for CSUMB Public Health Department, and I'm helping the program along with Ricardo. Thank you very much.
And I want to acknowledge Diego because he does a good job interpreting, and it looks easy, but it's very hard to do. To listen simultaneously.
I do it with pleasure.
You do it very well, brother. Thank you. Anyone else? If not, we'll bring this back, close public comment session. I'd like to bring this back for, make a motion that we consider option 2 to increase enrollment to 3,500 and then establish a waitlist if we get to that point. Is there a second?
Four seconds.
Yeah, that's right. We'll take Supervisor Salinas and Mary Adams, a third on that. Okay, further discussion now from my colleagues. Sorry, Supervisor Parker.
I guess I agree that increasing the enrollment will help more people, and I think also be a sort of a prudent step and keep us pretty much within the parameters of the money that we've set aside. I think we probably also want to ask or try to prevail upon Dr. Gray to continue the funding for another year. So I think really asking him to see if that's possible from the dividends budget. It clearly is a benefit for the community. Really a very low per member per month cost for the value of what's being offered. And then the other thing, it sounded as though Director Jimenez was expressing a willingness to explore finding ways to be able to offer some of the non-invasive cardiology testing, whether that would be covered by the program or whether there just be more outreach about ways for people to get the best possible pricing on some of those tests.
Yes, I will definitely take that back to Dr. Gray as well as the request to continue funding into fiscal year 18-19.
Thank you. And I did just want to thank our third-party administrator for helping us with the enrollment and fielding questions and helping us track how we're doing and what we're doing. It's really helpful to have that expertise on board. So thank you.
Thank you. Others? Supervisor Salinas?
Thank you, Mr. Chair. Let me just thank certainly COPA and all the organizers that have been advocating for this. It's been very heartwarming to see your compassion and your passion for healthcare, which should be a right, not a privilege, as we've heard of other needs, but also your willingness to understand. We have some very difficult budgets, and we certainly sometimes look to the state or to Washington, and they're just not coming forward with the level of funding that we need to probably have universal healthcare for everybody. So this is a good start. I think the 3,500 will give us also some data as we look to the future. As a member of the Natividad Board of Directors, I will relay the request on this board that we look forward to continuing to fund Esperanza Care, and at some point hopefully be able to expand it some more. But I certainly want to thank all of you. Gracias a todos los hispanos parlantes, las familias, miembros que han venido aquí. Ricardo ya la conozco por muchos años, ha estado abogando por la comunidad, y para todos ustedes escuchamos sus peticiones y esperemos continuar expandiendo este programa para darles salud y acceso a salud médica a los residentes aquí del condado de Monterrey, sin importar su estatus de edad. Gracias por estar aquí.
Gracias.
I agree with him, I think. But I echo the point that the COPA people are so committed to health care for the people, and they have me on a bit on speed dial, but I gotta really respect them for their commitment. So, and as you say, health care should be something that we're all entitled to. It should.
Supervisor Adams. Okay. And lastly, I just want to thank you.
Sorry, I just had one more thought, and that is, I would hope that, in the next 6 months or so, as, we kind of move into the next fiscal year, that we might look at whether it's possible either to have some of the other healthcare systems help support this, if we're going to look to expand it further just within our system. They might provide some financial support or explore other providers who might be willing to also join in, so that we have tens of thousands of people in the county who might benefit from this, and the county clinics and Natividad do a good job, but we aren't everywhere. So it does seem that as we start to have some predictability about what the costs are, we're in a good position to ask some of our other healthcare partners in the county to step up and either support the work that we're doing or also join in. I'm thinking particularly about Clínica de Salud. They've got clinics, widely throughout the county. If they'd be willing to participate as well, it would just expand the benefit to more people.
I do have one more comment. I just wanted to give a special thanks to Jack and to all of the volunteers at COPA.
Yes.
The work that you do is just really remarkable. And as someone who's active in the community, you are my inspiration, because the work that you do is grander than the rest of us. I just thank you all so, so much.
Lastly, not only COPA, but building health communities, the young people, especially the immigrant community leaders. We deal with every meeting, every Tuesday, we deal with a wide range of issues. But sometimes when it comes to important programs like Esperanza Care, which has the right name, it's about hope. We don't have those voices too many times at these meetings, which are held when many people can't attend during the day, it's during work hours. So those who could attend, I appreciate you championing this. Not only getting a program started, but then continue to work with our health department and our hospital leaders to make sure it's properly being adjusted and serving the community as well as possible. But I do like to remind everyone, it wouldn't be possible with county services. We had a report earlier today about our county budget. It was very difficult. We have some tough decisions to be made, but our hospital is doing well, and that's because it has community support. We have a trauma center, and these are our public dollars. So I just have to put in perspective that when we have a good, strong hospital or healthcare system, we're able to provide more services that otherwise we couldn't afford to fund and to provide to the community. So this is one of those examples where the community has worked with their county government and our department directors to really have a successful program, and it's become something that we could all really be proud of. So with that, I call for the vote. All those in favor?
Aye.
Motion carries unanimously. Congratulations, everyone.
Some places are new. Not everybody was here before we went into the Board of Supervisors. So if we can just go really quick around for introductions, use your name and what institutions you have a connection to. We can start with María. Vamos a hacer, como tenemos caras nuevas que no estaban aquí al comienzo de la reunión, para que sepamos quiénes estamos, si podemos hacer rapidito nada más un nombre y si tienen conexión a una institución. Hola a todos, buenas tardes. Soy María Luis con el Grupo de Salud para Todos.
Hello, everybody. I'm Cesar Lara. I'm with the Monterey Bay Central Labor Council and Building Healthy Communities, and of course, a member of COPA and co-president.
Yo soy Elsa Berreta de Salud para Todos.
Mi nombre es Joshua y estoy con el grupo Salud para Todos.
Y Carla Rodríguez, Salud para Todos.
Consuelo Rosales y el Juárez.
Smithy Smith, I'm a member of the Inpatient Church in Aptos, but I live in Monterey County.
Alfonso Hernández, uno de la comunidad de CISA, de la iglesia San Francisco Javier.
Jeff Hurley from St. Mary's by the Sea of Church in Pacific Coast.
María Rendón, San Juan Bautista Church at CISA. Mónica Palomo, de Salinas. Silvia Rodríguez, de Salinas.
Salud Torres,
Carolyn Douglas, St. Mary's by the Sea.
Marilena Manso, Sacred Heart Church, Salinas.
Beatriz Trujillo, de COPA. Kathy Murray, St. Mary's by the Sea Episcopal Church in Pacific Road.
Juan Juliana, Salud para Todos.
Celeste Ventura from St. Mary's Episcopal Church in Pacific Road.
Brett Post, Pacific Road,
Entonces, primero me gustaría escuchar de aquellos que expusieron su caso, en público, cómo se sienten, qué tal se sintieron tomando ese rol activo de dar su testimonio. So I first would like to get some reactions from the people who were part of public comment. How did you feel? How was that for you?
Yo me siento contenta. I feel fine. I feel happy for the result.
No, yo me siento muy contenta y muy agradecida con todos ustedes, ¿verdad? Que apoyan. Gracias. Porque a través de ustedes yo he podido beneficiar mi comunidad. Y eso me hace sentir a mí que estamos haciendo algo bueno y algo grande para nuestra gente. ¿Verdad? Entonces, pues yo me atreví, me levanté y pues aquí estoy como comunidad, apoyando a mi comunidad. Muchas gracias por la oportunidad que me dieron de que pudiera hablar y de presentar humildemente mi comunidad que no necesita.
Driven. Emocionada y gracias. María.
Did someone translate that?
I'm very excited that more people are going to be able to benefit from this program. And I'm really honored to be able to voice
Bueno, me siento muy feliz y con la esperanza de seguir comprometiéndolos a ellos para que nos sigan apoyando, porque de antemano así solamente nos seguirán apoyando, haciendo nuestro voto, hablando. I have completely forgotten about the presentation, but let me do Consuelo. So Consuelo was really happy, and it was a good opportunity for her to make sure that that commitment is still there for our elected officials, and through speaking up and they're able to make this commitment, move through these commitments. I know it's getting late, people probably need to get out of here, but a couple of comments from our organizing learning experience, right? So the first one is that even though this is a really good outcome, the helper team, it's not that surprised because we worked really hard to make sure that we were going to get the outcome that we wanted. So Maria, Andrea, Cesar, Jesus, Jan, Andy, a bunch of people, Alfonso, we have been to meetings with the supervisors individually to make sure that they understand where Esperanza Care is at right now, and to also understand where community and through our stories to see where will be the best direction for Esperanza to continue to move. So even though these are really good news, they're not necessarily that big of a surprise to us because we have been doing the work behind the scenes. Thank you. I don't think of the term in Spanish. I couldn't think of that term in English. Las bambalinas, it sounds more like festive. So that was really good that we have done that work. Thank you to all of you that have been part of those individual meetings. This is part of our work, and that's why those smaller meetings with elected officials are important, and also with the health department. So now in Spanish. Entonces, parte de la lección de organizar es que esta sorpresa, bueno, esta decisión, aunque es muy buenas noticias, no necesariamente es una sorpresa para los que hemos estado haciendo el trabajo de organizar los esfuerzos de Esperanza Care, porque el equipo de salud se ha estado reuniendo con los supervisores, se ha estado reuniendo con el departamento de salud para asegurarnos de que el progreso de Esperanza Care se está moviendo en la dirección que es mejor para las personas de las que estamos escuchando historias. Esa es una estrategia muy importante de organizar, que no venimos a llevarnos sorpresas, sino que venimos a reiterar el trabajo que hemos estado haciendo detrás de bambalinas, como les decía, que se me ocurrió la palabra en español, pero no en inglés, ya la pude usar. Entonces, esa es una parte muy importante que a veces no lo vemos, pero que es muy importante ser parte de estos otros esfuerzos también. Any final remarks from other people, something that I'm skipping?
Did you notice that a number of the supervisors were talking about funding for next year? That wasn't in our pitch.
Quiero recordarles que hoy la junta con el supervisor Alejo va a ser en la tarde a las 6 de la tarde en la escuela Martin Luther King, y van a estar preguntando a la comunidad en dónde queremos que el dinero que va a estar entrando de la marihuana, a dónde queremos que se vaya. Entonces les quiero hacer la invitación otra vez para ir a esta junta y volver a decir, ¿verdad?, que Esperanza Care es importante para nuestra comunidad y queremos que siga la inversión para este programa. Entonces, hoy a las 6.
I just want to comment and congratulate all the people that worked on the recruiting and registering of the people for Esperanza Care. This started like in August. In a short amount of time, we've registered 2,500 people, and I'm sure that within another month, we'll be able to get that 1,000 to have the 3,500. So congratulations to all of you. You did a great job and outstanding work that you did. Thank you.
Thank you. César, you were going to
Iba a decir lo que dijo María, y buen trabajo a todos y a la lucha. Esa no es la última junta. Thank you. I was going to say what Maria was going to say, but the biggest thing is the fight's not over and we have other meetings to go to, like the cannabis.
Go ahead.
I just wanted to say I was really encouraged by, for example, Supervisor Parker talking about bringing in other healthcare providers. That's not going to be easy. There's a lot of work still ahead but her vision, and maybe the vision of the whole board, to include tens of thousands rather than thousands in Esperanza Care in the future is really, really heartening.
And Supervisor Parker has been an ally to think about this, but I think our meeting with her last month was a reminder for her that when we started this project was with a wider vision for the future that included branching out to other providers. So what she was mentioning up there was part of a conversation that we had at her office. So María was there, Jack was there, Alfonso was there. So Esmiri dice que parte es también lo que decía la supervisora Parker, de que nos extendiéramos a otros proveedores que no sea solamente dentro de las clínicas del condado, y le menciono que ella ha sido apoyado y ha sido una aliada de nosotros, pero lo que ella estaba mencionando ahí, de alguna parte conforma una conversación que tuvimos con ella el mes pasado, y eso de lo que ella hablaba ahí era parte de lo que hablábamos en febrero. Alfonso también estuvo allí, de que cuando comenzamos Esperanza Care era la idea que fuera continuando hasta que nos extendiéramos a otros proveedores. Just one last thing, speaking of next steps with what Maria was saying, I have a date for an informational session in St. Mary's here in Salinas on April 5th. So if there's anybody who would like to be part of the organizing team or who would like to do some outreach for that event, I'll be happy to work with that person. I don't have a big team yet. I only have like 2 people, and then I know some people from Comité who are interested. I just nailed down that date last week, and this week has been going by faster than expected. So that's the other, in case that you know of leaders that are interested in being part of that.
It's good that you're doing that fast, because Sally's going to do information that the Sacred Heart, it's going to gobble up the other 1,000.
Yes,
She said today it was going to happen in a month.
La otra parte que dijimos en inglés es que tengo una fecha para el 5 de abril hacer una sesión informativa en la iglesia de Santa María aquí en Salinas, por si hay alguien que esté interesado en ser parte del equipo para organizar eso o para hacer reclutamiento de personas que vengan al evento, se pueden poner en contacto conmigo. Y that's it. Good job, everybody.
Good job.